So our next speakers will be presenting on careers in emergency services. Joe Pick is the Executive Director of the Firefighters Burn Institute. He's a retired fire captain for Metro Fire and currently a paramedic. And then we'll hear from Dr. Katie Baker, and she is an emergency room physician and the medical director for Mercy Hospital in Folsom. Remember, there's going to be ample time for questions after all the panelists speak. I personally think this is one of the most interesting topics that we have. So as a reminder, please put your questions in the chat. And Joe, you are up first. Please take it away. You're on mute.
There we go. Sorry about that. Students, thank you for having me. It's my honor to be here. As Lindsay said, I'm a retired fire captain, and I still am a licensed paramedic. I have not given that up, although I do not practice right now. It is something I worked really hard for, and not willing to give it up. I think what I wanted to do is talk to you guys about kind of my journey and how I had a series of opportunities throughout my career where I had to try something different. I was pulled to try to do something more, to learn something more, and take my the job that I do to the next level. So I'm going to kind of give you a quick overview. Basically, in 1985, I decided to join our local volunteer fire department up in Amador County. And I did that because I watched our theater burn down to the ground. And I knew I wanted to do something in my community. I was out of high school at that time, actually had my first child at that time. I started pretty young. And I will tell you, in high school, I had no idea what I wanted to do. I knew I wanted to do a physical activity. I was looking at heavy equipment operating, different aspects like that. When I got to join the fire department, a series of changes happened to me in my life. And the first thing I found was that we don't go to a lot of fires. There's certainly, more and more fires that we've had lately, but the predominance of our calls were EMS related, emergency medical services related. So I had to get a CPR card to be able to do that. But in order to be able to actually treat patients and connect with patients, I needed to become an EMT. And to explain what an EMT, emergency medical technician, that's the first level. It's basically critical interventions and stabilizing patients. Our job is to get air on scene and do those critical interventions that need to be done right now. Stabilize that patient and then get them to the ER and basically try to hold that position where they're make sure that their condition doesn't get any worse. So obviously in the CPR, compressions, ventilations, and control bleeding. And part of what I learned, especially having little kids at that time, was how valuable that tool was for me in my personal life, both with my kids, with family, with my parents, knowing that if something happened, that I could do some basic things. And I wanted to touch on CPR real quick. That's the first minimum requirement you have to do before progressing in the medical profession, certainly in the EMS profession. Now with hands-only CPR, the amount of civilians that are doing CPR and with the availability of Aeds, which are a automatic electrical defibrillation device, to be able to make a difference as a civilian. Because for us as the fire department in urban areas, we're probably about 6 minutes out. You get up in the rural areas, you're 10, 15, 20 minutes out. If things aren't done on an immediate basis, even by civilians, controlling bleeding, stopping bleeding from happening, doing compressions, helping a choking patient, by the time we get there, the likelihood of positive outcome decreases immensely. So I became EMT. I still didn't know. I figured I was going to be a volunteer there. And the more I got involved, the more I decided that this is what I wanted to do for a profession, which meant going back to school, getting fire science certificates, and educating myself in the fire profession. I was successful with getting on full time, but I will tell you, prior to that, by that time I had 2 kids at home, and I came home and told my wife that I was going to quit my decent job. I was working in a warehouse, good benefits, and I was going to quit that job to take a part-time job for a fire department to help get my foot in the door. Probably one of the scariest decisions that I made at that time, because of the difficulty I was going to be putting on my family. I set a goal that within 2 years, I was going to get hired by a full-time department. And when I wasn't working a 24-hour shift, I was in school taking classes, expanding my resume so that I was a viable candidate for the fire department. I got picked up in '91 as a full-time firefighter, as an EMT, which now is rare because they're looking for paramedics. I was happy I had that job. And within 2 years of that time, I realized I wanted to do more. So I was an EMT with a paramedic department, an ALS, Advanced Life Support Department, which meant every rig had a paramedic on there. Well, I found, once again, I needed to be challenged. I wanted to do more than just fetch a gurney and take blood pressures. I wanted to be the person that assessed the patient and give that higher level of critical interventions, medications, intubations, putting a tube down their throat, starting an IV, things like that. The other steps that help us stabilize these patients, so especially with our trauma patients, so that we can get them to a trauma facility and get the care that they need. There's certain things out in the field that we can make a difference in. There's medical conditions, diabetic conditions that we can deal with. Even heart attacks on some level, they still need advanced care. But there are other patients that need transport immediately. Our trauma patients are those type of patients. I can't fix arteries that are bleeding, bones that are broken. That's what our trauma surgeons do. A stroke patient, there's nothing I can do for a stroke patient other than try to stabilize them and get them to the hospital. So part of our job is to figure out whether or not the acts that we are going to do are going to make a difference right then, or whether or not we need to get them to a hospital. And that's, I think, what I really loved about being a paramedic. As the paramedic, you're in charge of the scene. You have a captain, a company officer that oversees the scene, but all medical decisions are made by that paramedic. And as a new firefighter, again, the fear I had going into that was high, but I knew I could do it, and I knew I wanted to do it. And then as I stayed a paramedic firefighter for a long time before I promoted, because I really loved that part of the job. I love meeting the patients, talking with them, calming them down, rendering care, and getting them to a higher level of medical care. So what I started doing was I started teaching, and this opened up some other doors. I started precepting students, which means that a medic, after they go through paramedic school, has to go out in the field with a preceptor, and that preceptor has ultimate decision, thumbs up or thumbs down, whether or not they become a medic or not. A lot of responsibility in that, and I took that part of my job very, very seriously. And it continued to open up more and more educational opportunities, not only within my department, but in other agencies. I worked for a private sector on the side. I went to other fire departments, and taught EMS throughout my career. And each one of those steps, because now I was an instructor with the department, when our department decided they were going to do a paramedic only academy, which they had never done before, I was offered the position to be the drill instructor, which means that academy is my academy. And it was academy that was geared just to EMS. And again, these opportunities started opening doors for me. I'm going to tell you a couple other opportunities. A lot of what I have done throughout my career has been a volunteer, because it's what I feel. It fills my soul. It makes me feel good about what I do. Started as volunteer firefighter. Did rock medicine for a while. If you've never heard what that is, at concerts, certainly in this area and in the Bay Area, they have an organization called Rock Medicine, Rock Med. And we work concerts and large events to be an intervention for those individuals that maybe have overindulged in a substance or had a heart attack, broken a leg, and we were part of the medical staff for that. A quick and very prideful story to me, my godson came at 16 years old in high school, not knowing what he wanted to do, way smarter than me, but and he started volunteering there, and just his interaction with the doctors that he was dealing with, the nurses, the paramedics, he decided he wanted to go to medical school, and that opportunity opened that door for him. And again, that's the big part of this spiel is there's a lot of doors that could open up to you, and I encourage you to reach out and try them. Moving a little bit forward, and again, in regards to volunteer and how I really got into this position is we have a camp at the Firefighters Burn Institute that's a Little Heroes camp for burn survivors under 6 years old. My wife is an ER nurse, and I was a paramedic, and because of my relationship with the organization, I was offered an opportunity to do medical for that camp. It's a weekend-long camp. Me and my wife discussed it in detail, and we both had serious concerns. How are we going to deal with this? She was an ER nurse, so they kind of do a rapid treat and then move them to another level. This was going to be a weekend where we were going to immerse ourselves with burn survivors under 6 years old. I will tell you that was a life-changing experience. As I've had many throughout my career. The first weekend we did it, we met a family that we fell in love with. She is 15 years old now. She was 5 at the time. And it showed me that this is something that I wanted to do. So I went from that to being camp director, of another one, doing things as a volunteer. And finally, when I retired from the fire service, I decided I wanted an opportunity to do something I've never done. Sitting behind the desk is not normally what I did, unless I was writing a report for the calls that we run. So coming into this position, all those steps, all those challenges that I had in my life that I said, I got to try it. I got to know whether or not I can do it. If I fail, I fail. But I've got to try it, because going back to the fire service and quitting my job, I told my wife at the time, I have two options. Either I try this and know that I've tried it and I've given it everything, or I say, I wonder what would have happened if I had tried that. And I will tell you, 35 years later, I'm glad I did not make that decision not to try it. And these steps have these opportunities have stepped me through my career. One of the other things I wanted to communicate to you guys is about volunteer efforts. And it sounds like you're getting opportunities for a lot of these different career paths. Coming in and volunteering, especially at this age, really gives you a sense of what you're drawn to. And if you try something that you think, oh, I'm not sure I would like that, but you try it, you might find that you got a passion for it. And that passion will drive you throughout your career and beyond. I, again, had no expectations that I would be sitting in this role 35 years ago when I joined the fire department. Looking at a couple no, I got, what was going to say? Well, the other thing I was going to say, and I touched on it a little bit, is just the simple education of getting your CPR card, becoming maybe a first responder, EMT, will give you life skills that will help you and help people around you. And I can't emphasize that enough. When the community helps an individual that is in need, prior to me getting there, the chances are so much better of a positive outcome. And so I encourage you to volunteer and try different things. So I think that's, Dr. Baker, I think that's kind of at least my first gist.
Yeah. Hi, everybody. Can you hear me okay? My name's Katie Baker. It's awesome to be here. Thanks so much for having us. So I'm an emergency medicine physician, and I'm also the medical director of the emergency department here at Mercy Folsom. So as an emergency medicine physician, that means Joe or someone like Joe, that we work very closely in how he's describing those initial interventions and that quick care that is given, right on scene to really help a patient and help really change the course of the direction they're going. And then when they come to our emergency department, then that's where we have essentially like a handoff where we can discuss what happened, what's bringing the patient in, what kind of treatment has been given so far, what has maybe worked, or kind of where they're at, and especially things like their vital signs, which includes their blood pressure, their heart rate, how fast they're breathing, their oxygen saturation. So I really got into emergency medicine, maybe haphazardly as well. Isn't that how we all kind of find our passions and find what our interests are? I definitely grew up playing sports and loved sports and team sports. And I still think what I do today is essentially kind of a team sport, if you will, where that job and that communication between someone like Joe and myself is, again, that team, that dyad that's very important. And then even amongst my department, I'm the physician, but yet I definitely rely on a whole team of people for us to be able to give the best care to these patients. So that's the nurses, there's techs, radiology staff. I mean, the list can kind of go on, but it's definitely a team effort to really care for these patients. So when I was in your shoes, I was interested in math and science, and definitely leaned towards taking more classes in that. Out of curiosity and maybe just some of your own natural knack for what you feel comfortable in and more sort of easily comes to you. And so I continued that into college. I did a program, and I think they're still out there now. And I am saying this, I agree with Joe's points of just kind of getting out there and trying stuff and volunteering, or even doing some job like around a hospital or in a clinic or anywhere. If you have some possible interest in healthcare, it's such a huge, broad umbrella, and there's so many different areas within that. So, maybe you want to be a doctor, and that's great. Or maybe you're interested in being a healthcare provider, and maybe something like a physician assistant might also be a really good option for you. So, I mean, there is just a raft of information and things out there. And I think the best way to do is to kind of get in there. And it's different than the TV show, don't think everything you see on TV is how it really is. But I think that does expose you and gives you just that, like, you're just in it, you get to hear the talk, you get to, see what people actually do versus maybe what you thought they did. And so I think that really gives you good exposure early on. So I like school. I like kind of the academic route. And I liked having a goal, and I kind of had an idea of how to get there. And I don't think life is always like that. But I did enjoy that kind of, checklist, so to speak, like, go to college, go to medical school, go to residency, happily ever after. And to be honest, we're always learning, we're always growing, we're always like looking for something more. And so, but I think you got to start somewhere. And I think you want to kind of put yourself in a situation that you start feeling it out early to see if that's something that does excite you. And whatever you choose or whatever you think that you're going to go towards, definitely make sure that for the most part, it brings you happiness. I think every job, every career has challenges. It has some difficulties to it. It has things that are not perfect, that you wish it was. But I think by and large, each day you really need to make sure that you're enjoying what you're doing, that you're feeling, gratitude for getting to do it, that you're feeling, that you want to go back and do it again. You're only going to be good at something if you really kind of deep down have that. So, I think some of it's kind of maybe some, what your kind of natural knack and talent is towards. But I also think that there's a lot to be said for just trying something, getting into it, trying to kind of experience it as best you can at the level you're at. And I think that will really help kind of guide you to continue to go in the right direction for what's going to be best for you, for sure. So yes, I was going to say a typical day in the ER is different every day. And I love that about it. I mean, there's definitely a lot of areas that we see kind of it's more routine to us. The complaints might be maybe more routine: abdominal pain, chest pain, difficulty breathing, like Joe mentioned, injuries, trauma, even just like cutting, lacerations, headaches, maybe minor injuries. Our facility is not a trauma center. Some facilities are what's like considered like a designated trauma center, but yet we'll still see more minor traumas, maybe like lower speed motor vehicle collisions. We see congestive heart failure. Has it ever been really stressful for you in the ER, and how do you cope with the stress? It can be. I enjoyed emergency medicine and my field, and definitely other fields that they refer to us as shift workers, right? So I have like a period of time similar to Joe that is my shift. And I like that, in that I know I can sprint for that period of time. And that I know that beyond that, then I'm, kind of off the clock, so to speak. Then I can plan my own, whether that's recovery, whether that means I need to take a nap, maybe I need to go for a run, maybe I'm going out to dinner with some friends, whatever that is, to kind of then reboot and have your own time, for sure. And it kind of goes in peaks and troughs, to be honest, too. So sometimes it's just pretty wild all at once. And similar to Joe, we're just constantly triaging things. I'm constantly prioritizing what needs to be done next, who needs my attention the most, who's the most critical patient, and how do I, touch that patient or do that intervention and then move on to the next, and then maybe circle back to that patient again and see how that intervention is going. So it's, it can be stressful. I mean, I don't want to say that it's not. I mean, I think Joe's world, similarly, there's definitely times that, your heart's pumping maybe just as fast. But it's also kind of exciting too. And it's an amazing opportunity to be the one that's there, that person is looking up at you and just being like, help me. They just want help. They just want to feel better. They just want to be, have their pain controlled, whatever that is, that they're just truly looking to you for help, and for your expertise. And so, it is but it's kind of fun to be like a master of that chaos too, you know? So each day you're trying to kind of like, control the chaos. And so, you know, I thrive in that. And kind of what Joe and I think both keep saying is to kind of put yourself in that situation. And it might be different than what you're expecting it to be, you know? And I think that's why we do all this training. That's why Joe's talking about all the training, all the, you know, you go through those worst case scenarios, you practice them, you go through it over and over. You know, I did 4 years of medical school, then followed by that, I did a 4-year residency program. And so from the beginning, I'm not the number one person in that, you know, kind of pecking order. So, you know, I watched the, you know, attending physician, you know, and I learned from the chief resident, and then I learned from, you know, the resident that was above me. And so that's what they call, you know, kind of the training within emergency medicine and the practice of medicine, and how you learn from, you know, your superiors, and some of it's you learn on the job as well too, you know. And so it's a constant. That's why I said there's no real finish line. You know, you kind of think like, oh, I'm going to go to this and I'm going to do school, and then like I just like live my life. But really, it's you want to continue to like be that master. You want to continue to like learn and be able to have what those patients need, and to be able to have those skills to provide that care to them. So I completed a 4-year residency program, and you know, one of my attendings would say, you know, when you first finish, you're not going to sleep very well for like 6 months, because suddenly then you're the one that's really at the top, even though you've been working your way towards that. And I think no matter what you do, there's probably some element to that in all kinds of industries, that then suddenly you're the one that they're looking at, like, what are we going to do? And it's like, they're looking at me, you know. But that's again, that's what all that training goes towards. And it's almost like deep down, like in your gut, like, you know what to do, and you just don't want to kind of let your head get in the way. So yes, so it's a bit of a chaotic world in the emergency medicine, but again, you know, I would really encourage you to explore all areas of medicine. I think something that we did not have when I was in training was scribes. And we have those here in our emergency department, and there's a lot throughout healthcare. And I do think that is a good, like, kind of fly on the wall start, that you can really kind of just start to like be part of the language. You know, you hear the physicians, you hear the paramedics, you hear the nurses, you hear like how everybody communicates. We have a lot of specialists that come into the emergency department too. So I think that's great exposure for our scribes. You know, they might not be totally sold on emergency medicine, but maybe they've had like numerous interactions with the surgeon that comes in, and they really love hearing when the surgeon comes back and, you know, says, oh, I took that appendix out, and like, you know, gives us the details and things like that. So I think it's a great way to kind of just like be in it. And then you really start to sort of see what you gravitate towards. I think there's volunteer opportunities in hospital settings as well, that you can volunteer as, you know, to be extra hand essentially in a hospital. I think there's also positions in emergency departments that is a tech, an ED tech. I oftentimes say they're the MVP of the ED. I mean, they're doing everything. Everybody's asking them for everything. I mean, they're in on anything. And so that's another great way to just kind of get exposure, you know, and, you know, just to, I think, put your voice out there. You know, things like this organization might be able to really kind of help get you there. There are local schools, I know, in terms of the education for a tech. I don't know if Joe's nodding. Did you want to comment on that more or no?
I believe American River
Yes.
in their health and health services program.
Yeah, has a program. And I think then local hospitals kind of pull from that. So that might be something worth looking into, you know, to kind of see, you know, what the commitment is and how you want to do. Joe, they're asking if you need a college degree to become a paramedic or EMT, and how long it becomes to become certified.
No, you do not. The EMT class is actually a semester-long class. Paramedic, They say a year, about a year and a half, pretty in depth because it's the didactic, your classroom, then hospital time, and we have to be in, so we do 3 months in every area of the hospital, OB, ER, cardiac, and different units there. And then you do 2 full months if you're on a full schedule out in the field where you put your craft to use. And that's about a year-long certification process. And they have those programs at our community colleges as well.
I also wanted to touch on just my position as medical director. So I'm an emergency medicine physician. I work clinical shifts. I was working this morning. And so each of us are kind of the leaders while we're on shift, right? I mean, we're the person that's given orders, that's given direction, that's, prioritizing, where our time and attention is going to go next. But I'm also the medical director, which kind of means I'm like the team captain of the doctors. So kind of, again, going back to like my sports analogy, I played soccer. I love team sports. And so it's kind of being, your captain. And so that helps us to be able to really kind of plan and to make sure that are we doing things, are there obstacles for our providers and our team while they're doing a shift? And how can we help either limit those or prevent those? How can we improve? We talk a lot about our operations, which essentially means like the efficiency of the department. So if you came in and broke your arm, I would want to get an x-ray on that. And I want to make sure that we have a process in place that happens as rapidly as possible and that we're getting you treatment as soon as possible, because that's all you care about is how much your arm hurts and you want to know if it's broken or not. And so we do a lot of things to really make sure that we're giving the best quality care, that we're making sure that everybody on the team is kind of performing to the expected standard, and really making sure that, we have kind of the slickest operation and that there's, no hindrance on, whoever is working that day, whoever is the captain that day, to be able to make sure that we're really giving good care to patients. So I think it's really fun to be a leader. I kind of found out early in my career that, kind of someone needs to step up to this and someone needs to sort of guide the crew and to make sure that, we're going in the right place. It doesn't help whatever sort of job or industry you're in, to just, have somebody complain like, this place and, why are we doing it like this and blah, blah, blah. And so some things, there's a lot of reasons and laws in place for why things need to be done the way they do. But then there's other things that we really can give our input, try to be more creative, try to really make this the best place, that we come to work. They say we spend like 80% of our waking hours, in your workplace. And so you want to make the most of it. And you want that to be enjoyable and you want to be able to help patients, right? So that's why we're here. I would say one last thing, just as a career in healthcare, I think is awesome. I mean, there's so many people you'll encounter in your life. And I really do believe deep down that everybody, whatever we do here on this planet, that we're all really essentially helping each other. But that I do really love, especially in emergency medicine, that we see every patient that walks through our door, just like Joe, he responds to every patient. There's no like screening or fill this out or something like that. We make sure that we are providing the best care to every patient that comes in. And it's just, it just really makes me feel good at the end of the day, and just like my life and like what I'm doing and how I spend my time, that I really feel like we are of value and like giving something back to our community. And so I just think that it's really important. And it just, it makes you feel like what you do matters, and so, and there's a lot of other things out there, and I rely on the postman to, bring mail and, everybody else, like, to make the world go round. But I definitely kind of have an extra little glimmer in my heart, knowing that, we get up every day and we just help anybody that comes in. We just ask them how they're doing, how we can help, in all sorts of ways. So sometimes it's physical problems, sometimes it's mental health that really needs that we're the kind of the safety net, and they just need somebody to be able to get them on that path to wellness. And so I'm kind of happy to be that person. So I'll quit speaking. I wanted to give just a couple little like kind of fun images, just because sometimes hearing just somebody talk and talk and talk is not that exciting. So I don't know if Sam, if you are able to pull up my images. I wanted to kind of have a couple little fun things, if that is possible still. If Sam is on, is that working? Okay, yes, here we go. So I did a few. We can just go to the next slide. I just put my name on there. Okay, so we see children, sometimes older patients as well, but typically children that swallow foreign bodies. And so it's always the question of, where is it? And is that going to cause harm? And does it need to, does somebody need to go in and go get it? And so I just wanted to kind of put a couple like fun images. That this one on your left is a child that had swallowed an earring. You can kind of really identify like the back of the earring there. And so that will pass through. So we always want to make sure, it's not in their lungs. So up above where you see the outline of the heart, what we call the heart silhouette, and then kind of the rib area and the dark area are the lungs. And so we want to make sure that when that foreign body went in their mouth, that they didn't like inhale it and have it go into their lungs, versus swallowing it and having it go into their stomach and then down, through their gut. And so this one is an earring, and then another one on the right then is a paper clip. And so far those are passing well. Typically it's higher up, sort of more up and through here, that there can be some more narrowing areas. And that's when it's a little more concerning if something is potentially going to be stuck, or are some of these something that we can just watch, do more conservative management and watch and wait. So there's all sorts of foreign bodies, but these are just a couple. And so that's always kind of an interesting one. Everybody wants to see the x-ray. The mom wants to see the x-ray. Sometimes the kid's old enough, they want to see the x-ray. Not everything shows up on x-ray, but something like this, that's more like metal is going to show up. So that's kind of just a fun one. Let me show the next image here. Let's see if I remember. This, I kind of just wanted to give you a picture of what's normal. So this is a normal chest x-ray. Black or dark on an x-ray is air, and then white is typically going to be more the bones. And so you can see their clavicle bones up high, and you can see that straight down the middle, that's part of what the spine is projecting, like the back of your spine that you can see. So it's a two-dimensional image of a three-dimensional person. So sometimes we have to take multiple views to be able to really look at everything. But I wanted to just kind of give just a normal, so you could see normal. And then the next slide I included, we're talking all about COVID, right? Everybody's life was disturbed and maybe more so. And maybe you yourself have had family members that had COVID, or hopefully not suffered losses, but it's just been it's been a crazy time for sure. And so I don't know if any of you hear on the news and things like that, if people would say like this COVID pattern, or when somebody gets COVID and they have to be hospitalized, or they have to be on oxygen, or even if they have to be intubated, which was similar to what Joe was talking about when we put a tube down and we put them on a machine and breathe for them. But this is a really bad case of COVID. And so as you can see, the biggest thing I want you to take away from is that loss of black, that loss of the dark. And so that was the airspace. That's where we breathe in and breathe out. And that's where we get that gas exchange. Whereas the lungs are just full. And so I sometimes refer to the lungs as like bunches of grapes. And so all those little surface area of your grapes, that's where we exchange the gases. We bring in the oxygen and get out of the carbon dioxide, the bad gas. Whereas when the lungs are so full, it's like that you don't have that same surface area to be able to exchange those gases. And that's what makes the breathing so difficult. And so as you can see, it just looks congested. It looks full. It looks uncomfortable. So I just wanted to kind of briefly, just sort of mention COVID, since we've all been so affected by it. And then I think I have one more. So again, this is so just some other things, kind of things that we do in the ER is kind of what I wanted to just give you a quick snapshot. We do a lot of things, but here's a few. This is a normal ankle x-ray. So we see a lot of patients that injure their ankles. Sometimes is it a sprain? You know, does that mean it's just more the ligaments that are injured, the soft tissues, or is there a bony injury? Is there a fracture? And so this is a normal x-ray that you can see. We have 2 bones in our lower leg, and then those connect. That shin bone is that bigger bone, the tibia that you see, that kind of wider bone there. And then the fibula is that more skinny one. And that's the bone that's on like the outside of your leg, whereas the shin bone is that bigger, that tibia bone. So then the next x-ray forward. So these are kind of an interesting, this set of 3. So the top one is somebody that Joe might bring in, okay, that has a fracture and a dislocation. So fracture is when the bone is broken. You can kind of see in some of these areas where it just kind of doesn't look right and the bone is kind of snapped. But then it's also dislocated, meaning it's no longer sitting in that joint as it should be. And so it's pushed forward. And so someone like myself, so Joe, this person would probably be in agony and just wailing in pain, because our body is not meant to have our joints out of place. I mean, it sends signals to the brain very quickly. And so Joe would bring this patient in, and then here in the emergency department, I would likely give them some medications so that they are pretty much asleep. So we call that a procedural sedation. So we give them pretty deep medicines so that they are still breathing on their own, not like the operating room, but that they are so unaware that they don't really mind me then having to kind of manipulate that ankle to really kind of get those bones back in place and to put a splint on. So this second row, you see that kind of bright white going around the foot and the ankle, and that is the splinting material. And so that's what then stabilizes that joint and helps keep everything. Otherwise, it's going to slip out again. And so we want to set it and then protect it. And the patient's going to feel better with that. And then the last one below is kind of beyond my care, is that then I pass it on to the next provider. So whether that's like an orthopedic surgeon or even a podiatrist that's going to do like foot and ankle surgeries. And that they provide really that definitive care. So you can kind of see some of that hardware, especially in the lower right portion of your screen, where you see all those like screws and everything in, and that really helps stabilize that bone so that then it can heal well, and that, you know, then this person can get back to living. So I think that's it. I think that's all of my slides, I'm pretty sure. Yeah. So I just wanted to kind of include a few. And then Joe and I definitely wanted to have some time for other questions, or I don't know where we're at on time, but to just kind of see, you know, anything, you know, what else are you thinking, or what else can we answer for you?
Anybody have any questions? You can put them in the chat. If not, we will move on to the next thing. Joe was going to share with us, what do you do if you happen across an accident? So Joe, do you want to talk about that?
Yeah, and and I'll incorporate it into, could be a vehicle accident. It could be somebody that has injured themselves on the road, I would say, or out in public. 2 things that are needed is 911 needs to be called. I use the term, we want the cavalry coming. I want to know that I got somebody that's en route. Even as a firefighter, if I was off duty, that's the first thing that I want to do. I want to make sure that you are safe. So especially in the vehicle accident aspect, is that if you see a vehicle and that's in an accident and you thinking you're going to pull over, you need to make sure you're protected. We see a lot of civilians, a lot of good Samaritans that get injured by trying to help other people. So making sure you're protected. If you're pulling over, you put yourself in front of their car. So if another car comes, it's not going to put you in harm's way. And this is where the critical intervention aspect comes into place. If you have somebody that has a significant bleed, you know, simple things like pressure, elevation, and we're even kind of getting back to more of the tourniquet, that if they have a significant bleed that's coming out, stopping that bleeding, that can be a life-changing thing. But again, there's some training that's involved in that. Get yourself safe. And then I would say on the other side, and this is why I want to apply this to not just a vehicle accident, but a family member is choking, stops breathing, has a heart attack. That CPR is going to make a difference. So those type of interventions and being trained in those and knowing what an AED is, and I think I misspoke. It's a automatic external defibrillator. Basically, when a heart goes, when a person has a heart attack, many times the rhythm that they're in is a ventricular fibrillation, which means the heart is just quivering. It's not actually pumping. That electricity that's applied to them and now can be used by bystanders because you put it on there and let it, and then follow its prompts. I'd say those are the two main things, the three things. Keep yourself safe. Make sure you're out of harm's way, no matter what. It could be a shooting. It could be something like that. You need to make sure you're safe first. Make sure 911 is called, and then perform basic critical interventions that you're trained for. CPR and controlled bleeding would be two of those.
Thank you very, very much for coming on and speaking to us today.
Thanks,
Thanks
you all.
coming in.
Thank you for having us.